I will go ahead and help kick us off with the Q&A. But real quick, I just want to have a little bit more of like a thorough introduction with Dr. Moster and Alyssa. Dr. Moster, if you want to introduce yourself a little bit about like your background and role at the GCC, and yeah, we can start from there, and then we can move over to Alyssa.
Sure, thrilled to do it. So I'm Scott Mosser. I'm a plastic surgeon, board certified plastic surgeon in San Francisco, California. And for many years, I did general and cosmetic plastic surgery. And then around 2008, I had the first individual come to my office who was on a gender journey. And that was a really successful and gratifying outcome on both sides. And then a few more patients over the next few years came in. And I really, really realized that I enjoyed the graciousness and the dignity and the connectedness that all of my trans patients were exhibiting, and I really wanted to dive in and serve the community more. So in 2012, we created a website that we felt would serve an information gap, would fill an information gap that we perceived was in place, and we've been trying to build on that website ever since then, and kind of since 2012 to the present, everything has been snowballing, moving forward, and this is what we do. We don't do any kinds of surgery other than gender surgery. There's 4 total surgeons working at the practice, and again, we all consider it to be a great honor to serve this population.
Great. Thank you, Dr. Moster. And Alyssa, your title is the lead insurance coordinator. And I think in your bio, you have mentioned that you also do a lot of patient facing. Your work is primarily patient facing. Could you tell us a little bit more about how that works?
Yeah, so my pronouns is she, her. I've been with Gender Confirmation since 2020 and currently manages the insurance department. Um, a lot of it is, prepping patients before submissions for with their insurance. So I dedicate my time helping patients navigate the complexities of insurance processing, supporting them in every step of the way to secure surgery approval. So, and advocating on their behalf to ensure they receive the coverage they need. So, from early on submission to their insurance plan, to advocating patients once the case is denied. So appealing with them is one of the majority of the things that I do that are day to day.
Great. Amazing. So we have one expert gender affirming surgeon, and we have one person who is a lead on insurance navigation and support for patients. So, within that, we have like a myriad of different questions that y'all can ask. Feel free to add those questions, any questions that you have in the Q&A. That is the best way to go. But I will go through some pre-written ones before we get to the live ones. So the first one that I want to ask is what are the base requirements or the first steps that someone should cover before they start pursuing gender affirming surgery with a doctor?
Great. Thank you for the question. Sometimes when I hear a question, I hear a little bit of the spirit behind the question, and I'm not sure if it serves the topic well or poorly. I think it serves the topic well, but we sometimes pull the lens back a little bit. So the question was really about what are the base requirements and first steps, like a really concrete ask. But one of the things that I've realized when people are starting to think about surgery is that there can be a real sense of an overwhelming feeling. And even to the point that you might dabble a little bit in information gathering, maybe on a website, but then the sense of almost dissociation can come up. That comes up to all of us when we have something that's just too much and it's overwhelming and it's a system that we don't really know anything about. So I first want to acknowledge that those feelings are actually real and normal, and they're part of engaging with this complex entity of the American healthcare system. And then with regards to actual first steps, boy, there's so many different answers. I'm not sure that it's a linear pathway, but some of the different things that are important early on would be if you are seeking insurance approval, then you'll probably need to get a letter of support. And a letter of support can be obtained from a mental health professional, and commonly that is required. But some insurance companies just require anybody with a doctoral degree or a mental health degree to be writing the letter of support. So think a little bit about that. If you're going to be thinking about insurance approval being important, then think about the different professional healthcare relationships that you have in your life and whether or not you have a mental health provider that you could reach out to that could help. And then I would say that an element of self-education in a couple of different ways can be helpful. So first, I would say lean into the community. There's lots of resources that are out there. There's resources at Plume. I'm sure there's a number of groups that I don't even know about, but I do know about some groups that are on Facebook, and there's Reddit groups, and there are many, many ways that people come together and share information to help them with their decisions as much as they can, and share information about their experience with the different providers. So getting comfortable with those community interactions, I think, would be probably pretty helpful. And to the extent to which you feel comfortable doing so, I think that starting to educate yourself on the procedures of interest a little bit. There are a lot of resources out there on the World Wide Web regarding these procedures. You probably would do pretty well just Googling some keywords about the procedures and finding some websites that seem reputable. We have tried very, very hard to provide a lot of information that's really useful. I know that there's other academic institutions out there. For example, Oregon Health Science University in Portland, Oregon has very, very robust educational materials that they give to their patients, but make widely available to the public. So that's another resource. And ultimately, I think if you're really serious about moving forward with surgery, then you're going to start to think about what surgeon is right for you. And so that's a long process and very nuanced. At a very high level, I would say seek information from the community and start to get comfortable with what practices seem to be very serious about this work. I think that like all surgeries, it's work that if you do a lot of, you're likely to get more consistent and reliable results. And I think that the people who are really serious about doing this work will have a lot more experience probably, and will also be more likely to have created an office that is very gender competent and provides a lot of psychological safety around the experience. So I kind of danced all over the place, but just reviewing that one more time, maybe it's letters of support might be important. Think about that. Think about a mental health provider connection if that is right for you. And then get widespread information about the procedure and start to educate yourself as well as you can. And then also connect with the community because those connections are out there and they're robust, and that can really help you.
Great. Thank you. Next question, I'll pass over to Alyssa. From your experience, what insurances are taken by most surgeons that would cover most of the cost of the surgery? And kind of like a side add-on to that too, like which ones would be easily accessible to folks who are low income?
Yeah, so the major health plans are basically the big, five: Anthem, Blue Cross, Blue Shield, Aetna, United Healthcare, Cigna, which are also the plans that we most commonly encounter in our practice with a high success rate of approval. The cost of surgery will vary depending on the specific benefits of each plan. And as for low income individuals, there is Medicaid, and the Affordable Care Act is available and can offer a range of health insurance options, varying levels of coverage based on the individual's income. Again, individuals may qualify for subsidies that helps reduce premium plans with Medicaid and Affordable Act, which is available to everyone.
Sweet. Thank you. And do you have any, I know this is a very broad question, but would you have any starting advice for folks who are looking to navigate the insurance process? I know that insurance can be so daunting. So yeah.
It is, and it can be very challenging. But I believe that, understanding your policy, securing the necessary documentation, like Dr. Mosser mentioned earlier, the letter of support from a mental health provider, and being really persistent can improve the individual's chances of success. Um, Working with healthcare providers, patients, advocates, and legal resources can also help to make sure that the individual get the coverage that they deserve.
Amazing. Thank you. And kind of last question for you for now. Do you need a letter of support before you book a consultation with a surgeon, or is that only for when you're using insurance?
I believe for top surgery, if you are using insurance, most of the health plans currently right now, they do require a letter of support from a mental health provider.
Cool. Thank you. For folks who are looking for support on navigating things around insurance, I'm gonna post the Trans Health Project. They have lots of information on how to look at your insurance. What did you call it? It's the benefits, the insurance benefits, and then if and when you do get denied, how to do appeals and everything. So yeah. Moving on for Dr. Mosser, what types of questions would you suggest folks asking a surgeon during their consultation to make sure that their provider is like knowledgeable and can ensure successful results?
Another great question. And once again, I'm going to pull the lens back a little bit and look at it a little bit more broadly. So, one of the things that I just alluded to was that I do think that it is maybe not the most important thing in the world, but somewhat important to try and select a provider that's really serious about gender care, that does a fair amount of this surgery. And at the same time, I think there's a non-codified element of when you're talking to a healthcare provider. Do you want to make sure that you really do feel like this person is treating you with the respect that a consultant would treat you? In other words, this individual should be empowering you with information. There shouldn't be this like strange veil of authority and this feeling that there's a black box of knowledge that completely resides within the other individual, and yeah, they'll make a decision on whether or not to take and do your case, but you're sort of left out in the cold with regards to what anything is all about and how it all works. You really should feel empowered, and that individual should be generous with guidance and information and understanding as you go through the process. So that's not necessarily what you should be asking, but it's what you should be feeling. You should be feeling respected. You should be feeling like this is a partner that you want to go through something with. And actually, you should feel like they're a good human, that if you happen to go through something that was much more difficult than expected, that this is exactly the sort of person that you would want to go through something difficult with. Because most of the time, surgery does play out exactly as expected, but a certain percent of the time there's unknowns. And in those situations, you want to be aligned with somebody that from the very, very beginning you've liked and you felt like was a good communicator and you felt like was well-intended and had your best interests at heart. So again, that's the broad lens. Now, kind of stepping up to the actual question itself, I do think that it's sensible to ask a provider, how many of your type of surgery they do per year. If it's one or two or three or four, it may not be something that is a real focus of that individual, and they may not have the knowledge and capacity to deal with the nuances of your physical anatomy. If it's somebody, on the other end of the spectrum that would say, yeah, this is all that I do. I built my entire career around this procedure, then I think there's a little bit more confidence. Well, maybe more than a little bit. There's a fair amount more confidence in that sort of a situation. I think that rather than having specific questions, I would say feeling confident that you have a place in that consultation room and you can and should be able to ask all the questions that you want without any like sheepish nervousness. You really should feel like you have a place, and many people come in well-researched and they'll write down a bunch of questions, and they'll come into a consultation, and whichever ones we don't resolve during the course of the normal consultation, then we'll do at the end. And I always like that, actually. I really like to see that a patient is engaged and is interested. I think kind of in the world of surgery, one of the worst case scenarios is somebody that's just checked out and they don't want to engage and they don't want to listen to this very robust risk and benefit discussion that can be had. We do have frequently asked question lists that can go out, and I'm more than happy to provide those to the audience. So I should have said this at the beginning. I predominantly personally do top surgery. So that's breast augmentation and then chest reduction surgery, mastectomies and aggressive breast reductions. combined also sometimes with body contouring. So body masculinization or feminization would be common terms for that type of body contouring. There are other surgeons in the practice that do facial feminization and also do facial masculinization and then bottom surgery, genital surgery of all types. So the questions that would be asked, the specific questions, would be very appropriate to each procedure type. But again, we have forms that we've put together that serves both sides, patient and provider, that are the genuinely, frequently asked questions with their answers, and we can provide those. And that also gives people, when you give those to people, it gives them kind of a sense of safety and security that, yes, indeed, they've covered all the bases. Because there is that like nagging feeling when you go through a consultation, and sure, your questions are answered, but you're not even really sure if you asked the right questions. And so this document kind of serves people to know that yes, they are well-rounded. Um, yeah, getting any deeper in sort of the topic would necessitate talking about a particular procedure type, and I think that's a little bit beyond the scope of this actual question.
Mm-hmm. Great. Thank you so much.
Uh-huh.
The next question that I wanted to ask for you, this one goes a little bit like further on somebody's journey, but
Mhm.
could you tell us a bit about the process of getting revisions?
Sure.
And what happens if you want to look for a different surgeon from the first? Is it difficult or frowned upon by the surgeon or insurer?
Oh, it's not frowned upon or difficult by anybody, not by the surgeon, not by the insurer. And remember, there'll be two surgeons in the situation, the one that did the first surgery, and then you've decided not to go back to them, and then the other surgeon that you would be going to. And 100% the surgeon that you're going to will not frown upon that at all. They'll probably feel honored, that you trust them enough to then seek a bit of an improvement. And just to be clear, what a revision is an initial surgery is performed. Something about that result is not as good as everyone had hoped, probably at least the patient, not as good as they had hoped. And yet there is a surgical technique that will allow for a better result. So it's a touch up. You're seeking an improvement in the appearance. Sometimes revisions are not just a touch up. Sometimes things look really problematic, and a revision needs to be very broad-based and comprehensive. It's a big surgery. But when a patient has an initial surgery and they're not thrilled about the final result, they have every right and should be entirely confident going to another provider in order to get that touch-up done. Insurance companies, at least from what I can tell, don't seem to have any problem with that whatsoever. Broadly speaking, for revisions, insurance companies might require for you to kind of go through some of the same jumping through hoops that happened the first surgery. So you might need to get a letter of support again that says that in spite of the initial surgery, the elements that are an issue are still problematic and cause dysphoria. And so in a sense, the gender journey is not complete regarding this procedure, and therefore it needs to be supported to completion. But I haven't seen problems switching surgeons. I have heard some very strange stories about, this is not mainstream insurance, strange stories about some insurance companies that just are problematic for revisions across the board. And I never understand that. And by the way, I don't want to give anybody any undue fear, because this is not usually the case. Usually, if an insurance company will support the first surgery, they'll support any revisions that go along with it. But I have heard of weird cases where they don't. And in that case, you'd probably be enlisting Alyssa's and the team's help to learn how to appeal those cases.
Great. And Alyssa, would you mind sharing a little bit more about what that appeals process looks like? Because I know getting a denial as a patient is very disheartening, but it is also part of the process too.
Of course. It's basically, I know it can take a longer process, but it's basically the same thing as like submitting. We're basically resubmitting the case for a second opinion, a different provider that's reviewing the case. And I do back Dr. Moster 100% in regards to revision. Majority of insurances, the major ones, do cover revision surgeries. And, it it doesn't matter if it was the original surgeon that did the initial surgery or a different one, as long as, like I said, like gender dysphoria is still here, and this is the reason why we're requesting for additional round of revisions. In regards to the appeals, it is, it can be a very lengthy process, but I do recommend everyone, I don't want a patient to just stop there once they receive a denial. I would 100% push them to go through the appeals, even though it will take, longer process. We need to push insurances and see them that this procedure is medically necessary for our patient. And, no matter how many times we have to do it, because sometimes insurance will say, oh, first level appeal is denied, second, we'll push for the second level until all the levels are exhausted on our end.
For sure. Thank you. And thank you for that work, as always. Would you have any tips for folks who are wanting gender affirming surgery but are in poverty or are on SSI, like disability?
Sorry, would that be a question for me or for Alyssa?
I think that might be for Alyssa. Yeah.
Sorry, can you say that? Can you repeat that one more time?
Yeah. Do you have any tips or advice on or resources, thoughts, opinions, broad strokes of folks who are looking to get gender affirming surgery while they are like low income or in poverty or on disability like SSI and receiving a very low amount of income from that?
I don't have I don't have the answer to that.
Mhm.
I'll write it down, and is it okay to get back and get some resources? Yeah, let
Yeah,
me
of
just write
course.
it down.
Sweet. Thank you. Cool. And then the last common question that I know we get often for you, Dr. Mosser, is there certain weight requirements for surgeries?
So for top surgery, there's basically not a weight requirement. The requirement is not even, probably not best couched as a requirement. It's a process to ensure medical safety as someone is on their way to surgery. So taking a step back, top surgery will almost always heal just fine, regardless of the size of the patient. So if we're just narrowing the lens to chest reduction surgery is performed, will the incision split apart just because the patient is large? The answer is, in our experience, no. We do not see higher complications for healing for top surgery for any body size. Now, having said that, the safety to undergo surgery is a potential other issue altogether, or at least something to be looked at separately. And we generally will work with the primary care physician who will look at systemic conditions and also unearthing any conditions. We might work with a cardiologist for an individual that has a higher body mass index, perhaps above a BMI of maybe 40 or 45. And that individual might request some pretty advanced tests, such as an echocardiogram to make sure that the heart is functioning properly and that the blood supply that goes through the lungs has a normal pressure in it. And then we also might work with our anesthesiologists who might look at the patient and do an in-person visit or a live video feed to actually look at their neck and look at their oral airway, have them open their mouth and see whether or not they see any cause for concern in that regard. So there might be reasons that are somewhat related to weight, but are really medical reasons that could lead to delays in the process of getting to surgery as those medical conditions are optimized. There might be some medical conditions, just like for any patient, that are related to weight, but are serious enough to make it unsafe to move forward with surgery. That can happen. Doesn't happen very often, but it can. Or there could be opinions by the anesthesiologist that would say, hey, we're not willing to do surgery in this environment, like an outpatient surgery center, but they are willing to do surgery in a hospital environment that has a number of layers of backup safety and other anesthesiologists and equipment carts for more sophisticated issues that might happen with airways and even a blood bank and even an intensive care unit. There's a lot that hospitals have. And when patients have more complex medical issues, potentially related to obesity, those would be the appropriate place for it. So The actual numbers, therefore, are for top surgery. There's no limit based on the surgery itself. For bottom surgery, my understanding is that that does play a role. So the nature of the tissues in the region of the groin and the nature of the space that the surgeon needs in order to do certain things, like create a new vaginal canal, those can be very impacted by body size and thigh size. I'm not sure I would be quoting accurately. I think broad brushstrokes, if a patient gets to a BMI of 35 or above, they might be in some potentially challenging territory for many bottom surgery procedure types.
Cool. Thank you.
Mm-hmm.
Kind of moving also into top surgery, this person asks, is there any types of surgeries for top surgery for folks who have large chest tissue that the sensation can still be preserved?
Mm-hmm. There's a new procedure that we're beginning to perform, and that's called double incision top surgery with free nipple graft and neurotization. So that last part, and neurotization, is a portion of the procedure where we begin the procedure as we usually would, make the normal markings and plan surgery in the usual way. And then at the very first part of the surgery, a surgeon will find and identify and dissect out a sensory nerve, a nerve that's responsible for sensation of the chest. And that nerve is a long nerve, and it's left attached to the chest. And then I will continue to do the entire procedure, the usual double incision free nipple graft as I usually would. And then when I determine where the nipple areola grafts are going to be, then the sensory nerve expert will use some, cool looking magnifying glasses that they wear and some loop magnification, and they will use some very, very tiny sutures to attach the nerve that's attached to the chest to another nerve that is present in the tissue just deep to where that nipple graft is going to go. And this is still fairly limited in our experience. It's a procedure that's actually been around quite a lot. There are many, many hundreds of patients that have had this sort of a procedure, but in a different population. It was developed more in cisgender women who are seeking a breast reduction, a mastectomy, a removal of their breast tissue for cancer reduction, risk reduction purposes. So in those individuals, you'd have all the breast tissue removed, but the nipple could be left behind. And then there's a reconstruction performed with a breast implant. And then most of those patients in the old way didn't have any nipple sensation or had considerable reduction. But with the preservation of the nerves, and in those cases, they might need a longer nerve, so they might even use a graft. Restoration of the nipple areola complex sensation has been very, very successful. So getting together with the surgeon that performs this work, we sort of thought, why not for the top surgery population? And there's a number of groups around the country that are beginning to do this work. And though it's still pretty early, I think we've done less than a couple dozen cases so far. But early indications over the last probably 18 months that we've been doing this are very, very positive. So we're getting the flatness that one would hope with a double incision free nipple graft. But because of the nerves being present, we're able to achieve a very significant level of sensation. Commonly satisfying erotic level of sensation, which is a very high level of sensation, of course, for the nipple areola area. So that's really successful and is fairly new. I didn't really expect for there to be any transformative new procedural stuff, but this has come our way, and I'm really excited about it.
That sounds amazing.
Yeah.
Very exciting new developments.
Yeah.
There's this question that I saw around whether or not you're able to get coverage for surgeries on Medicaid or Medi-Cal. Alyssa, would you have any answers around that?
I'm sorry. Yes, so Medicaid and Medi-Cal do cover gender reassignment surgery. We do see a lot of our patients with managed Medi-Cal that gets 100, approval for surgery. So a lot of times, just checking your benefits, making sure that there's no exclusion on the plan. And like mentioned earlier, again, it's obtaining your support letter from your mental health provider is very important.
Great, thank you. Kind of continuing with the insurance, somebody asked, is it easier to get approval with a PPO or an EPO? And which one has better approval rates in your experience?
I would say, it's more of like the time of the approval. A lot of times with the PPO plans, we get faster approval turnaround times. With EPO, depending on who manages the plan. Because when we talk about EPO and HMO plans, we start talking about the actual health plan and the medical group, right? So a lot of times the risks of who's at risk for surgery can be split into half, and so that can kind of prolong the process of the approval. But I always say that, support letters is very important, and as long as we kind of show the medical necessity and that the patients met all the requirements for surgery, then the approval is going to be on its way.
Great. Thank you. Is there an age limit to getting gender affirming surgeries?
So there is a very, very robust process for patients that get to gender affirming surgeries. Not all surgeries are available to patients. And it definitely adds considerable challenges and barriers and some cost to care. And in most cases, people are not commonly doing I can't speak for all institutions, but there are many institutions that are not commonly doing any surgeries below age 15. Some institutions say nothing below 18. I think that the pathway that leads to surgery is a very long one and longer for anybody who is an adolescent. And it's a very complex and very responsibly complex process. So patients commonly, when they're starting in the pathway to surgery, will not actually be able to get surgery until they're very close to 18 or 18 anyway. So that is a common thing. I think more and more the more robust these processes get. So while I can't comment for all institutions throughout the entire country, I can say broadly speaking, some institutions have an age limit, and then some of them just end up seeing patients that are sort of close to 18 anyway, because it is something of a considerable process to get to surgery.
Mm-hmm. That makes sense. There are a couple of questions around bottom surgeries, and I know that that's not something that you specialize in, but would you still be able to answer some based on your knowledge?
I'll do my best and I'll tell you if I can't. Yeah, and if
Great.
nothing else, then we can get the answers to you all after.
Great. Is electrolysis the only option for hair removal before bottom surgery, or can medical grade laser hair removal be used?
That's a great, okay, so I can't actually answer this one, fortunately. So one really wants to minimize as much as possible or hopefully completely eliminate hair for all the different procedures that are involved in bottom surgery. As you can imagine, there is, for some types of bottom surgery, you're actually using what's called a radial forearm preflap. So very, very thin skin and fascia nerve and blood vessel layer that is utilized, for example, to create a phallus. And that's how a phalloplasty is performed. And some of the skin is used to create the urethra, the tube through which urine flows. And then some of the skin is used to create the outer surface. You can imagine that you wouldn't want the skin that is in the urethra to be producing any hair at all. In some ways, same thing for vaginal skin lining. You wouldn't want pretty much any skin to be being used in the vaginal area if it's still producing hair. So the question is commonly, how can we get nearly all of the hair completely gone? And laser hair removal is a hair reduction technology. And it can do a number of different things. It can sort of stun hair to the point that it stops growing and eventually continues to grow, but at maybe a little bit of a smaller, kind of a finer, more towards baby hair sort of a nature. or it could treat all of the darker hairs, but be unsuccessful at treating all the lighter hairs. And so it could be like an impartial, a partial, sort of imperfect treatment. Electrolysis is where you're literally zapping the generative component to each hair follicle. So you're using electricity to actually create a heat reaction at the base of it and try and actually kill all of those cells that are responsible for producing hair. So it can be more of an all or nothing thing. You still need to have a bunch of different sessions because not all hair follicles are producing hair at any given time. But um, I think that for the stakes of the game that are really quite significant for hair reduction, you need to go for the most reliable approach. And electrolysis is generally that for these sort of high stakes situations.
Thank you. And somebody also asked around like, are the nerves of the sexual organs able to be preserved during gender affirming surgery? And that's kind of both masculinizing and feminizing.
Yeah. For feminizing, it's actually a bit more straightforward because that tissue is left intact. So there's some tissue that's in the glans area of the penis, and there's nerves that go into that region, and then there's a neurovascular bundle which is preserved, and then it's placed in the region where it would develop in some individuals, and that would be basically right where the clitoris is. So on the other side of things, it can be a little bit more challenging. And when surgeons are creating a phallus in a phalloplasty surgery, there's actually two types of sensation that are really important. There's protective sensation. One needs to know, when there's pressure on a body part that might be compromising the blood supply, that it should feel uncomfortable. It should hurt. So there's protective sensation, and then there is erotic type sensation. And those are different nerves. And that's kind of one of the fascinating and almost magical things about this radial forearm free flap area is that there's multiple different nerves that serve this as well. So the nerves can actually be plugged into these different areas and hopefully attain both erogenous and also protective type sensation. That's the goal. And I would probably let a microsurgeon and a phalloplasty team really speak to their incidence of success and how they actually go about it all.
Amazing. And for folks who are getting like a vulvoplasty / a zero depth, can a canal be created later? And if so, what procedure would that be?
Yeah, there's some area. So the answer is overall yes. This is some hot topic in the world of gender because there are more complications associated with the creation of a vaginal canal. And so there's some topics regarding, well, if you could create the vulva and not subject someone early on to the creation of the vaginal canal, but maybe find a better time in their life for them to dilate and engage in the postoperative process that can be quite demanding and complex. Is that sensible? And there's really two sides. There's the side that says, no, it really should be done all at the same time. It's a big surgery to go through regardless, and it really should be done once. And there's the other side that says, well, what can we offer to people who really aren't ready for or don't want the involvement of the vaginoplasty? Well, other than alluding to the conversation being out there and being in the realm of expertise, I should probably leave it there because I don't think that I have the expertise to really weigh in on which side I would have a strong feeling about.
For sure. Thank you.
Mm-hmm.
This question is for Alyssa. How difficult is it to get a surgery approved out of state and out of network?
It's not as difficult as a lot of people think. So we need to make sure that the patients have a out-of-network benefits for one. And from there, it goes through the regular process for authorization. In terms of out-of-network, here at GCC, we accept most, if not majority, of all insurances. And in the event that a health plan is out of network with our office, then what we do is we do another round of like an approval or basically asking for a letter of agreement. It's a one-time agreement where, the insurance and our office can come into terms so that the patient can be seen even though their insurance is not a participating plan with Gender Confirmation Center.
For sure. And in your experience, has insurances covered things around like hair reduction or like hair removal
Oh, yes.
for, yeah,
Yes, they have.
cool. How would one go about claiming that as like something that's
That's
medically
medical
necessary?
necessary.
Yeah,
So, our surgeon, typically how the process here at GCC is that Dr. Lay would, write an order for the patient, getting ready for surgery, for their surgery for the future, and then the patient will just choose of which clinic they want to go to, and then start the authorization from there.
great. Thank you. Kind of going back to surgery related things. Sorry, I'm like looking at the chat, looking at the live questions, looking at this list of questions that we have from other folks. This question is for you, Dr. Master. Could you describe more about what body contouring actually is?
Sure.
And then kind of what that would entail for either feminizing or masculinizing?
Sure. So in a broad basis, um, feminizing body contouring is addition of curves, and masculinizing body contouring is reduction of curves and creation of perhaps a more rectangular shape. And if one could, effectively do so with liposuction, create more of kind of like a V shape to the back. That can be a bit more challenging. The biggest challenges with body contouring, and basically what we're talking about here, is liposuction is the main tool. And then for adding of curves, you can do fat grafting. So liposuction in masculinizing is usually what's used. Most of the time, there's minimal fat grafting performed in masculinizing body contouring procedures. And then in feminizing procedures, almost always there's some element of fat grafting if it can be done. Because there's usually areas that one would definitely like to see more curves, and adding some fat into those regions can be very material to do so. Um, and um, and so the challenge is that the underlying skeletal structure commonly has a shape which has already been determined during puberty, and that's basically the foundation of all the body structures, and that can be the limiting factor. So when the hip girdle is wide, like when somebody undergoes an estrogen-based puberty, then that can be one of the contributing factors of the sort of width and the curvatures in that area. And there's only so much that liposuction, which of course doesn't modify the bones, can do to reduce those curves. You're kind of sort of trying to blunt out the curves and make them look less visible overall, or maybe at least help somebody fit a little bit better in their clothing. And then the opposite is true as well. If you don't have that sort of foundation of a wide hip girdle, then building curvatures on something that's much more narrow can be more challenging. So we think of body contouring as a refinement procedure. We don't generally think of it. I mean, it can be transformative in select individuals, but a lot of the time it's a considerable improvement and a refinement, but not a full transformation of body shape.
Amazing. Thank you so much.
Mm-hmm.
And this next question is all about HRT when it comes to trans affirming surgeries. Like, do you have there can be a number of these like rapid fire. Like one, do you have to be on HRT in order to receive surgery? And then two, are you able to stay on HRT before, during, and after the surgery? And what does that look like?
So there is no requirement to be or not be on HRT for most surgical procedures. That was perhaps a thing many years ago, but it's definitely not a thing in this day and age. Do you have to come off of HRT? Well, you certainly don't have to come off HRT for top surgery for most institutions. Some institutions feel more comfortable taking patients off of hormones if they're going to have bottom surgery, because they're going to be kind of sedentary for a while. They're not going to be up and around moving, and they worry about the possibility of blood clots in the legs for individuals that aren't moving and are on hormonal supplementation and hormonal medications. And then I had another thought there. Let me see if I can remember what it was. Oh, I think that the starting and stopping of hormones, people that are opponents of starting and stopping would say that there's a lot of emotional ups and downs when you start and stop hormones. And there's a lot of emotional ups and downs with surgery. And so it would make sense that if we don't absolutely have to stop hormones, for us just to not stop them. And so opponents of starting and stopping hormones would basically just try and get people to mobilize as quickly as possible and to protect them in other ways from blood clots in the legs. And those are basically the two schools of thought that are out there. But because for chest surgery, people are walking basically immediately after surgery, that day and the following day, most institutions would not feel strongly about taking somebody off of hormones around that time of surgery.
Great. Thank you. This is a little bit about facial surgery. I'll just touch on one of these questions. Somebody had asked about if you're able to talk about some of the minimally invasive options for facial surgeries. This one was about facial masculinization, but it's open to both.
Yeah, that could mean a few different things. There are some minimal scar approaches for things like tracheal shaves, and I can't speak with a lot of experience about that other than knowing that they're out there. There are when people say minimally invasive options, commonly they're talking about things like injectables, and those can be effective. So that would be for perhaps the chin, creating a bit more chin definition and projection with injectables that are injected right into the layer just above the bone. Some individuals might do some injectables along the jawline as well in order to make that more prominent, or you can actually inject Botox into the jaw, and that causes the muscles to relax, and that causes for the prominence that's related to that chewing muscle, the masseter muscle, to then soften. And so those are the things that come to mind. I'll bet that somebody that is deeply entrenched in facial gender surgery would have a few other ideas, but those are the things that come to mind for me.
Amazing. Thank you. This is around a typical timeline that people would expect for surgeries. What is a typical timeline that somebody should expect in terms of wanting to get a surgery to it actually happening?
Well, it depends again on insurance approval, and it depends on if there is a relationship that is made with a therapist. Some therapists will find that individuals really very quickly meet the criteria for being approved for surgery. Other therapists would want to engage in a process of investigation and learning about the patient and learning about their sort of life experience, and then would feel comfortable recommending. So I really can't speak to that part of things too much. Once one gets to the point that they are seeking a consultation, then I would say that it might be 3 to 4 weeks, I would say, maybe up to 6 weeks maximum to get a consultation for top surgery. Bottom surgery there's real access to care issues, and so bottom surgery can take a bit longer to get a consultation in many institutions. And then you get the consultation. There's an insurance approval process, which can be 2 to 3 weeks for top surgery, but can be months potentially for bottom surgery or other more complex procedures. And then there's the scheduling of the surgery. Once you get approval, then you're put on the schedule, and that'll depend on the individual surgeon's wait time. So at the GCC, with 4 surgeons available, we have fortunately not super long wait times. We're able to usually see patients have patients on the schedule within 3 to 5 months without much trouble. But there are institutions that it can get a bit longer, especially for more complex procedures.
Got it. Thank you. Now, in terms of surgery recovery, I know that each surgery has a variety of different needs for recovery, but do you have anything you would suggest to support folks who need to cope or prevent some of the pain after surgery?
It might be a bit out of my league because in top surgery, it's usually very manageable in the vast majority of patients. There can be some nerve sensitivity syndromes where pain can be a challenge, but even then we have some tools available to us that are quite effective. I would say the other, facial surgery and bottom surgery can be a little bit more significant and also take longer to work through it. So I'll stick to what I know. For top surgery, it's usually about a 3 to a 5 on a scale of 1 to 10 right after surgery for most people, unless they have a real sensitivity issue. And then by 7 to maybe 10 days, they're getting completely off of any narcotic pain pills and just getting to Tylenol if they even need that at all. And then I would say after that period of time, pain is usually very minimal. They'll, be getting a bit more active at 3 weeks for cardio, and then at 6 weeks for heavier lifting. Um, and there may be a little bit of discomfort there, but it's usually not too bad. So I haven't seen for top surgery procedures that pain is a big deal, but for bottom surgery procedures, it can be a bit more involved. And I'd probably have to again defer to the experts of those fields to set better expectations than I could.
Got it. Thank you.
Mhm.
Now, in terms of piercings, do you have to remove piercings before surgery? And two, how long do you have to wait until you can put them on? I'm
Yeah.
assuming it's like for facial and also for top surgery too.
Yeah, it depends on if the piercing is right in the sort of the line of fire, right where you're going to be doing the surgery, then piercings do need to be removed, generally speaking. The other thing that is a consideration about piercings, though, is if they're metal, there is a theoretical concern. I certainly have never seen this in my practice, but it could happen, where we're using electrocautery, which is electrically grounded, to do a lot of our work and our dissection and our control of bleeding. And if somebody had, for example, like a metallic earring, and just by bad luck and an unfortunate circumstance, it was connected to something that was grounded, the electricity could actually exit through that piece of metal and could burn the person in that part of their body. So for that reason, operating rooms really, really like to see non-metallic components when they're present but out of the field. The other thing is that generally speaking, things that are right near the airway, the anesthesiologists are not super thrilled about foreign bodies that possibly could fall into the airway while they're doing some sort of a intubation or an onset of anesthesia. And so that's another really good reason to have things removed. So I don't think people would actually cancel surgery if you couldn't remove them in most cases. And there are some metallic things that just cannot be removed. And in that case, everybody communicates about the risk, and they put tape on it, and they try and minimize anything ever happening. But if at all possible, they're removed. They could be replaced immediately after surgery if they're not in the zone of operation. If they are, then I would talk to the surgeon. Or they could be replaced by either an acrylic, a plastic, or potentially a glass component that would be non-conductive.
Thank you. And this question is kind of for the both of y'all. Do y'all have any best post-surgery products for recovery, things that you've noticed work really well for patients or things that they have talked about?
So we have a handout that we give everybody at the postoperative visit for top surgery, and it's actually quite a bit general. I don't think that there's a lot of magical products that are out there, just to be clear. I do think that silicone treatments to scars can help scars heal in a way that's perhaps a little bit less thick and a little bit less red. So we would recommend to patients that when all the crusty stuff is gone from their incisions, that they would maybe go to Amazon and find a silicone-based, maybe tape or tape strips or possibly gel that has a lot of reviews, and it seems to be a really solid, really easy to use product. And most of those are all created equal if they're silicone based. For chest surgery, since we're tightening tissues, rarely people can have stretch marks as a result of us actually tightening the tissues. And for patients that are at risk for stretch marks, we would recommend for them to do a twice daily treatment of some sort of an emollient like shea butter or cocoa butter, and then in the other part of the day, a bio oil. And those just seem to like soften the skin to the point that they don't have the stretch marks appearing as a result of tightening. So that would be what I would recommend. And I don't think there's a lot of magical stuff that's out there that's expensive that anybody just has to buy.
Sure. Great. And curious if you have any thoughts if you engage in that area too, Alyssa, since you're patient facing.
No, I don't, unfortunately, but I have heard patients share with the other staff, like our medical assistants, that bio oil really works.
Amazing. Cool. This one is a unique question, so I wanted to ask that here too. This person says that they are AMAB and have a breast from taking estrogen, but they would like their breast tissue removed. Does that complicate things? And would they have to approach it differently, or could they still do the same surgery as like top surgery?
Yeah, I have seen this happen before. It would just go through the regular process. Not everybody's gender journey is going to be the same. It's unique. And if this is something that is causing gender dysphoria, then certainly there's established procedures that could improve things for that individual. So only seen this a handful of times in my life, but it's something that we've been able to successfully address with the usual approaches. Usually I've only ever seen it in conjunction with somebody that has a mental health provider that can provide a letter and help everyone understand context, and then we do, and the patients. Again, the few patients that have had these sorts of non-standard procedures have been very, very happy and satisfied that basically you just follow the dysphoria, you treat the dysphoria, and then on the other side of things, there's nearly always a fantastic amount of satisfaction.
Amazing. Thank you.
Mhm.
And then we're kind of getting towards the end of time, but I would love to still ask a couple of questions. You had touched on the complications that one might face receiving a surgery if they are overweight, but would there be any for those who are underweight?
Underweight would only usually be if somebody was undernourished. So if they didn't have enough nutritional components for them to be to have successful surgery. Again, I won't speak for bottom surgery, which might be different. Perhaps there's lower limit of BMI for bottom surgery surgeons. But generally speaking, for top surgery, we just want to make sure that everybody's going to heal and heal uneventfully. So sometimes when somebody has a very, very low weight, it's because they just don't have enough protein in their body. They have a something in their life or medical history that is contributing to a state of being malnourished. And we would probably do some tests, probably check their blood count and their albumin and prealbumin and make sure that they seem to have enough protein to engage in normal metabolic functions. And if they did, then I can't see a reason why that would be a problem.
Amazing. And would you know of any studies for folks who have gone through gender affirming surgeries, maybe like 10 or 20 years afterwards? Someone was just curious about that.
Sorry, could you ask that question again? It glitched out there
Um,
for a second.
yeah, do you know if there's any studies around folks who are receiving gender affirming surgeries that kind
Uh-huh.
of, yeah, for folks who are like 10 or 20 years after they had that surgery?
Yeah, there's many studies from Europe, especially, that show exactly what you would expect, which is a very persistently high level of satisfaction over procedures that are related to transition. Um, I don't have any of the studies like top of mind or the references, but I think we'd be able to get you that.
Right. And I think to kind of cap off for the last question, this is around, things around the federal government is going to be changing soon, around like federal funding and methods to provide gender affirming care for trans people. Um, I think people are just asking about your thoughts around like Project 2025. How is that going to impact gender affirming care? Are there going to be any changes or methods that you are going to do
Mhm.
to continue supporting folks? And that's both for you, Alyssa, and also you, Dr. Mossing.
Yeah, I can't speak to anything about Project 2025. I've heard it. I've heard the thing mentioned in the media, but I don't know the specifics of it. I'm an apolitical person. I'm here to treat people and help them, recapture their lost bandwidth that is problematic because they need to transition in order to get on the other side of this challenging situation that they're in. And it's very, very effective for us to do so. Our practice is in California, which is a state that is very, very supportive of trans individuals and people in transition. I am unaware of any, governmental sort of reach to control the healthcare access of or healthcare policies of individual states. There may be some conversation about federal funding of procedures, but again, I'm just kind of following it like everybody else is. I think that the private payers and the companies that are out there that pay the bills of the private payers and pay for the health care of their workforce are all very much in favor of this care continuing. And so I'm not really seeing any greater trends of the removal of care, on my radar.
For sure. And Alyssa, do you have any thoughts, opinions about this?
Um, like Dr. Mosso said, we are here to provide care for our patients. Um, and the same thing, I don't think there are going to be, any changes with the private plans insurance. And we're just, well, like everybody else is watching,
Mhm.
closely watching
Yeah.
everything.
Great. Thank you. And again, just wanting to provide some resources for folks, especially in terms of something like this. I know I saw a couple of people in the chat saying they're they're not sure if their insurance can approve their surgeries in certain different states. I'm gonna send the trans equality page for the Trans Health Project. This helps break down ways that you can advocate for yourself and also do appeals for insurances. Also, I remember a couple of conversations we've had, Dr. Moster, where there are instances where folks' insurance doesn't explicitly say that they cover the surgery, but when you do advocate for yourself, you're able to get that approved. Yeah.
Yeah, yeah, I've seen that as well. And also working, if you have a company which is supportive, you can work with the HR department of that company, and they have a voice with the insurers and can commonly come to your side and help move things along.
Yeah. Yeah. And so even if it says it doesn't say anything about covering surgeries, it's not always necessarily a no. I think it's just like it's always a process of us having to advocate for ourselves, which is kind of just what is going down in general in the first place. And so highly, highly recommend to just, use this Q&A, use these resources to stay informed and to be able to make empowered decisions and like to be able to advocate for yourselves. There's also just like no local and national trans law centers generally who are down and able to provide like support and resources around those too. So yeah, kind of wrapping up for this conversation, I am going to, send a list of resources at probably, if not the end, hopefully if not the end of this week, it would be around the middle of next week.